This is Dave Rosenblum from the NRAP Academy. Last night I did a webinar on the why and the how of regenerative medicine, integrating it into your pain practice with ASIPP. They have a great meeting coming up in March in New Orleans. I suggest you check it out. In addition, I have been invited to co-direct the ASPN Ultrasound and Regenerative Medicine Pain Workshop in Miami this July. So if you did not sign up, go to ASPN as well and sign up, register for the course. I'm going to run it with Dr. Ali Valimoed, who is another experienced interventional pain physician, and we've been doing that course with a few other talented physicians every year. This is my first year they asked me to co-direct, so I'm very excited to do that. They put on a great conference just like ASIPP. So last night I did a lecture with ASIPP, and they asked me to discuss the why of regenerative medicine, why to integrate it into your pain practice, idea as to why the integration of regenerative medicine into your pain practice is a must in 2026 and beyond. So we traditionally looked at interventional pain management as just treating the pain itself as a disease and ablating or modulating the nerves to decrease pain, not so much actually targeting the pathophysiology. I mean, we would use steroids to reduce inflammation and pain, but steroids don't heal. You hope that the body heals to some degree on its own. Steroids and RFA do not take care of the health of a tissue. So let's take the knee, for instance. The knee is a great joint to use as an example because you can burn the nerve to the knee. You can modulate the nerves to the knee by doing a nerve block or by using a peripheral nerve stimulator or even a DRG, a dorsal root ganglion stimulator, but you're not doing anything for the actual joint. So when a patient comes to me with knee pain and they want to discuss their options, well, I ask them what their goals are. First of all, if they don't want the knee replacement or if they want to put it off for a longer period of time, I would suggest trying to preserve the joint, assuming it's not end-stage bone-on-bone and there is something that you can work with. So what I'll offer patients is a viscosupplement combined with a regenerative medicine technique, typically PRP or bone marrow aspirate concentrate. I know a lot of other doctors are offering fat stem cells as well as, and I'm trained in that, and I may start doing that, but for now, I'm sticking mainly with PRP and BMAC in my practice. There's all sorts of products such as Wharton's jelly and amniotic fluid or placental stem cells, and they are potentially very effective and very low risk. However, there's still not a lot of research done to make them more mainstream, and the FDA is not so excited about physicians doing these types of procedures. That being said, as a physician, I think you need to just look at the individual patient and explain what we know about the product and what we don't know, and let them decide for themselves as long as they truly understand what's going on. I think education is the big key when it comes to treating patients in pain, as well as regenerative medicine. You want them to see the problem from your point of view. So when patients tell me, oh, don't give me a cortisone shot, I don't want just a Band-Aid. Well, first of all, you need to give people a reality check. As we get older, everything degenerates. Everything goes downhill. Regenerative medicine is not going to grow you a new meniscus, not at this point in time, but it will heal and repair and probably restore some degree of function that will make them satisfied with the treatment. It's going to take an inflamed, damaged tissue and heal that damage. Will it make a disc herniation go back into place? No, not really. But it may reduce that inflamed nerve root size, so there's more room in the foramen, so they're not as symptomatic. It will also modulate that soup of chemicals or mediators that are being released by that damaged disc. So orthobiologics or regenerative medicine procedures, PRP and BMAC, I'd say are the most commonly performed. BMAC is bone marrow aspirate concentrate. It has mesenchymal signaling cells. It's quite powerful. And then the exosomes are basically what the cells release to make them work. There's growing patient demand for non-surgical opiate-sparing solutions, with the whole campaign led by, I guess, the government or physicians, I don't know how you want to describe it, about reversing the damage done by big pharma, the medical industry, and the media with respect to the opiate crisis in this country, people don't want opiates, thank God. People don't want surgeries. And people have become mistrustful of big pharma since the pandemic. They've been mistrustful of physicians as well as healthcare in the government and the policies. So people want to treat the problem and not become eternal patients or dependent upon medications. And this is basically the crowd that I cater to. I just try to solve people's problems so that I don't make them an eternal patient. And, on that note, people say, oh, PRP is a big money maker. Actually, it could be a money loser because you're solving their problems and they move on with their life, which is great. And you hope that they refer their friends and family, and that's how you grow your business. So chronic pain is driven by tissue degeneration and inflammation. The targets are degenerative disc disease. You could do facet arthropathy, tendinopathy, ligaments that are lax, osteoarthritis. PRP delivers growth factors that modulate inflammation. It stimulates collagen synthesis and tissue repair. It improves joint and spinal biomechanics. It addresses pain generators at a biological level rather than a neural blockade. There's growing evidence that for PRP and orthobiologics, there's effective treatments, especially the PRP. The evidence is mounting. So when a patient says, my friend did it, it didn't work, the first question is, how much did they pay for their PRP? If it was $100 or $200, they're not using a high-level double spin kit that takes 60 to 80 mLs of blood. They're probably using a test tube that costs $10 or a very cheap kit, and it's probably a single spin. There's a huge difference in the way PRP is prepared. If it is not effective, ask what was used. Ask the platelet count. If you see a study saying that PRP is not effective, look at that study very closely. Maybe it wasn't, but look at how they did the PRP, because the definition of PRP, according to some, is 3 times or 5 times or 10 times the amount of platelets. I usually strive for at least 8 times the amount of baseline platelet concentration to get the best effects. PRP has been shown to improve pain and function versus corticosteroids and versus viscosupplement long-term. In my PRP course, in my regenerative medicine course at NRAP Academy, I quote a study that is a meta-analysis that shows after 1 year, the patients with moderate arthritis who received PRP had better relief than steroid group as well as the viscosupplement group. The viscosupplement are the gel shots, of course. It's established as a treatment for rotator cuff, patellar, and tendinopathies, as well as lateral epicondyle inflammation or tendinopathy. We're injecting it into the disc with radiographic signs of improvement, facet pain, SI joint dysfunction. Just yesterday, I did a case where a patient presented with coccygodynia, pain of the coccyx, radiculopathy, foraminal stenosis, inflammation near the disc at L4-5, L5S1. And the patient presented, I did a ganglion impart platelet-rich plasma with a low lidocaine injection, as well as posterior to the coccygeal ligaments for the coccygodynia, and injected into the caudal space to get some PRP and lidocaine into that caudal sacral area where there was pain, in the hopes of maybe you're going to get some spread into the epidural space for the radiculopathy, as well as maybe some of that lidocaine by the nerves that innervate the pelvis that will give some relief as well, and go up to the L4-5, L5S1 region. And then I went to the left-sided L4-5, L5S1 transforaminal space to not only get the PRP lidocaine mixture on the exiting nerve root to reduce pain and inflammation, but to get it close to the disc where there was obvious swelling and inflammation on the MRI. Now, if the insurance was paying for a procedure like this, you can never do all these injections at once. They would look at you as some sort of pig gaming the system or over-treating the patient. But when you look at the patient as an individual, not the cookie-cutter approach, and you see what exactly is going on with their pain and what they're here for, the patient's paying for the procedure themselves. So the goal is to safely treat them and get it to work, whether it's 1, 2, 3, 4, or 5 targets in one day. Insurance companies don't like that because it costs them more money. And they don't like, they try to keep us within the realm of cookie cutter medicine where we have to adhere to their guidelines, their policies in order to get reimbursed. So Regenerative medicine has the added benefit of flexibility when the patient is actually paying for their care. And the goal is to just do what you can to get them out of pain and get them better. And you're not limited by a third-party payer. Many cases where we've delayed, avoided surgery, or we've used a PRP to take care of pain after surgery. I've done it for everything: neck pain, back pain, shoulder pain, as well as knee pain. Even after a knee is replaced, you could put platelet-rich plasma around the regions that are painful, the genicular regions, the genicular nerve targets, as well as where you find an infusion on the ultrasound. I have a partner who I'm currently treating with PRP for his post-operative knee surgery fusion. He had a replacement, and the orthopedic is telling him, no, PRP is not going to work, but he tried it and it's helping. So regenerative medicine adds another dimension to your practice. It can help you grow. It can position you as an innovator and future focused. It attracts younger patients who don't want surgery, drugs, or to deal with being a monthly follow-up patient where you're always getting drug screened or taking opiates or some sort of medication that they can't get off of and has high risks. It may enhance referrals from orthopedics and it may not. Unfortunately, a lot of primary care doctors aren't aware of the evidence and that it is becoming more robust by the day. The safety profile, a lot of people still think these are just quick ways for doctors to make money instead of ways to solve problems. And unfortunately, orthopedics, while some of them will do PRP themselves, which is great, but some of them may not refer patients for PRP because it may decrease their surgical numbers because of, like I said, PRP can avoid surgeries. And there's a lot more going on in the realm of regenerative medicine with the stem cells, the exosomes, and eventually, the peptides, which is a whole nother discussion. I have a podcast on that. Basically, patient satisfaction with regenerative medicine is quite high. I tell patients anecdotally 70% success rate, 30% of patients waste their money. It varies. It's probably a little higher than 70%. And this is for physicians, this is a cash stream where the patients pay for it themselves. You don't need a prior authorization or to deal with denials or clawbacks. And you have some control over your income and maybe tailoring something for the patient's individual needs. You can actually go back to treating patients the way you want to treat them. And when patients say it's too expensive, I can't afford it, well, that might be true for some patients, and that's unfortunate. It's probably cheaper for them than doing the copay for 2 years. If it solves their problem, it's probably best. And it's definitely healthier than the same amount of money they could spend going to New Orleans or Vegas for a weekend and taking, eating unhealthy and drinking alcohol and staying up late. So, patients do need to take responsibility for their health. I'm sure many patients spend more money on alcohol, cigarettes, and soda in a given year than they would on a given PRP shot. I'll throw fast food in there as well. Of course, you need to be trained. Most interventional pain physicians have the skill set to place the needle, but they do need the ability to process the cells or the plasma properly. And, you don't need to take my word for this. This is a recent advertisement video of patient testimonials I put together for my pain practice. And I'm going to just be quiet right here and let my patients speak for themselves.
It's like every 3-4 months I was getting a cortisone shot just to get by. My orthopedist wanted to do replacement, and I didn't want.
So the PRP prevented you from getting shoulder replacement?
Definitely, I recommend it.
PRP takes longer to work but lasts longer.
It's better than a cortisone shot.
The PRP was fabulous. I had it in July of 2025, and now it's going into December, and I've had no problem with it. Believe me, the recovery is 100%. I am so happy that I did this.
Robert, you suffer from back pain. You had PRP into the facet joints. Okay, would you recommend PRP for other patients?
I would.
Great.
The best thing they ever invented.
Are you more active since we did that PRP shot?
Yes.
Wonderful.
In the neck was miraculous. I regained range of motion within a few days. The back, and I would say 80% relief.
Which, in the real world, if the insurance companies were involved, I would never be able to treat all of her problems in one day. But because she did PRP and she covered the costs herself, we had the flexibility done it. We're 2 weeks out of your PRP shot. How are you feeling?
I feel pretty damn good, I have to say. I feel amazing.
What did you have done?
I had the PRP to my cervical spine and it changed my life. I'm a new person. I feel unbelievably
What did you go
good.
through before the PRP?
I had a pain in my neck and the violent headaches and down my right arm. It's all gone. I did the PRP and it changed my life. I'm a new person. I feel amazing.
So basically, my patients speak for themselves. If you're a patient and you're looking for a regenerative medicine pain treatment, I'm in Brooklyn, New York, 718-436-7246. If you're a physician looking to get trained in image-guided procedures, regenerative medicine, reach out to me via the podcast or nrappain.org, where we do pain management board prep, ultrasound training, in person and online, as well as regenerative medicine training. Thanks for listening. If you like the podcast, videocast, webcast, etc., don't keep it a secret. Please share it with your colleagues, patients, and feel free to use my video if your patients are on the fence about PRP, because I think everybody knows somebody who tried PRP, it didn't work. You need to really find out why it didn't work. What did they give? And if you can't, explain to the patient that everybody's an individual and there are different ways to do this. And most of the time, you get what you pay for. Thank you, and I wish you all the best.